Good afternoon, everyone. Welcome to our panel today on transgender health. We're so excited to have all of you here, and I'm especially excited to have all of our panelists with us today. I just wanted to welcome everyone on behalf of the Women's History Month planning team, and thanks to all of them for their efforts in helping put this together, with a special thanks to Meg for really doing a lot of hard work tracking down all of us and making sure that we're on par here today. So thank you all. I'm going to turn it over to our session moderator, Frank, and I will let you take it away. Thanks so much.
Thank you so much. Thank you everyone for being here. My name is Francisco Gallarte. I'm the director of the Feminist Research Institute. I'm also an assistant professor in American Studies and Women and Gender and Sexuality Studies here at the University of New Mexico. And my areas of specialization are Chicanx, Latinx, and transgender studies. In addition to this, I edit the only cultural studies based journal on transgender studies called Transgender Studies Quarterly. And Transgender Studies Quarterly is now has its new home at the University of New Mexico. So this is a start of what I hope are many conversations around transgender studies, issues, and important topics like transgender health. So I'm going to go ahead and introduce our wonderful panelists. And of course, I want to thank them all for taking the time to be here. And thank you all who took the time to attend this panel session. I'm going to go ahead and go in alphabetical order, and then I'm going to give an initial get a started question and allow everyone the opportunity to chime in. And then I'll give some follow-up questions if that sounds good with everyone to the panelists. Yeah? Perfect. So first I'd like to introduce Dr. Kathryn Crandall. Dr. Crandall is an emergency physician and public health researcher at UNM. His research is focused on health services, research, and gender-based violence. Since 2015, he has served as the Associate Vice Chancellor for LGBTQ Diversity, Equity, and Inclusion. In his role, he helps to guide and advise UNM HSC to better respond to the needs of LGBTQ faculty, staff, students, and community members. Dr. Crandall was a physician leader in the health system's revision of the electronic record to recognize and honor patients who are sexual and gender minorities. Our next panelist is Bunnie Cruse, who is the chair of the Transgender Research Center New Mexico Board of Directors. Bunnie has been a staple in the LGBTQI+ community since 1994. She started her community building with the United Court of the Sandias, UCS, at age 21 and was elected Empress at age 28. At that time, Bunnie also joined the Youth and Transition Board of Directors, which provides direct services like food, clothing, and shelter for LGBTQI community. And this is what Bunnie is most passionate about. She believes that her lived experiences as a survival sex worker, being homeless, and her battle with addiction are her biggest strengths when it comes to serving the community because she understands their struggle. In addition to serving as chairwoman of TGRCNM, Bunnie serves on a Light in the Night Leadership Committee and the International Court Council, and has served as Queen Mother of the UCS since 2013. Thank you so much for being here with us today, Bunnie. Next, we have Dr. Ed Fancovic. Dr. Ed Frankovit is a professor of medicine in the Division of General Internal Medicine who joined the UNM School of Medicine faculty in 1998. He practices primary care with a special interest in the care of the LGBT community. And he also provides HIV prevention and treatment in a primary care setting. He has been the interim dean of undergraduate medical education in May 2020 and oversees the planning and implementation of the medical student curriculum. Next, we have TK King, who is a second-year medical student who is part of the LGBTQ Student and Allies in Healthcare group. They worked with their colleagues to implement a transgender care curriculum for medical students. And finally, we have Kathryn Stuenkel, who provides transgender care and wellness services at Truman Health Services. So again, thank you so much, panelists, for joining us today. And I'd like to just go ahead and begin us with a general question. And I guess if folks can comment based on their experience as educators and also practitioners on the importance, what you understand to be kind of the central elements of comprehensive trans healthcare. So, why should we talk about trans health? What are some kind of best practices and what are for Bunnie specifically, what do you see kind to be needs of the trans community in terms of healthcare? So whoever would like to get us started, that would be great. And I'll keep track of time and then see if we have time to move on to another question and everyone has had a chance to speak. Thank you.
Well, I can start since I'm the oldest one. Again, I'm Dr. Ed Fancovic. I am in primary care, and I work a lot with the LGBT community. Over the past close to 40 years that I've been in practice, healthcare for transgender individuals has been going through a steady transformation. Originally, it was something rare and exotic, which was only handled by a limited number of endocrinologists who specialize in hormone management. Surgeons who worked with the trans community were next to impossible to find, and usually only in large urban areas. As trans visibility and inclusion has increased over the decades, the model of healthcare delivery has been changing steadily. It's moved from a very subspecialty based sort of practice to more of a recognized need, where we have dedicated clinics now for transgender health, and Dr. Stuenkel can talk more about that history within our own institution. Eventually, we would like to move to a model where more and more transgender healthcare is being incorporated into a primary care setting, such as what I do with the transgender patients on my panel, where their primary care doctor handles the hormonal management, makes appropriate referrals when needed for special surgical services. The surgical services are starting to become more readily available in smaller communities. But that's been sort of the trajectory that I've seen in my own practice over close to 40 years. And I invite the other members of the panel to add to that.
Let me just add a couple of sort of just general structural issues that I think that have impacted the way that we respond and provide care. Traditionally, we've had, as Ed pointed out, a specialty model approach, and it has tended to focus mostly on adults. And so one of the things that I think is really I'm looking forward to is really providing care across the ages. And we don't have Molly McLean currently on the panel, but she really took leadership of working with kids who have gender diversity, and really can, I think in the model of family medicine, provide care across all ages. So starting from children through adolescence and into adulthood. So I think that's one of the great ideas of sort of moving this from specialty care into primary care, is that you can have some consistency. And just the only thing I just want to make a brief comment on, which is really the Affordable Care Act and Section 1557, which is the law which basically said we need to provide care to trans folk and not be discriminatory, I think has really propelled the entire healthcare community to be much more responsive. And I think that we do have to recognize that great advancement during the Obama administration really did have a lot to do to push care much more forward.
I guess I'll go next. I sort of see, in my experience, this moving towards primary care model, but also this sort of like de-supremacizing, I guess, of primary care for trans folks, like as in trans folks are generally often treated like the expert in their life in primary care when it comes to their transgender healthcare, because providers are sort of humble about it and also a little bit uninformed. But as that changes, I think that we still need to keep this element of treating our patients like experts and involving patients in decision making. This is like one of the central tenets of trauma-informed care, is giving your patients power. And I think that transgender care is one of the places where this is sort of already happening by accident, but we need to be intentional with it and treat patients like the experts in their own experiences, their own health, etc.
I'll go next. I agree with that wholeheartedly. That is fantastic. And it is something that I experience every day. So just a tiny bit more background on me. I am a family medicine doctor. I come from a little bit more of a place like Ed, where I previously was doing like just as part of primary care, I was doing transgender affirming services. But now it is kind of my daily life, and the majority of the work I do is gender affirming services at the Truman Health Clinic. And I also do get to see age 13 and up, which is huge, because if you're only saying that you're seeing 18 and up, you're kind of too late for a lot of folks. And so I'm really glad that we're doing that. I agree that one day the dream, the plan has to be bringing this into every primary care clinic and making it a part of the training for everyone who plans to do primary care, because that is the dissemination that this information and ability needs to go, I think. So right now I do work in kind of unintentionally, we're specialized just because Truman is kind of a haven at the moment for being able to provide those services. But down the road, I really do hope that it goes to everyone who's doing primary care. Also, I would just say that if the question is what is needed to provide healthcare, something that I wouldn't have thought of maybe a couple weeks ago is just the legal ability to do it. And so like what is going on in Arkansas is terrifying. And so we all need to be aware of that and keep working on that and making sure that we're allowed to provide these services, which, yeah, number one. Thanks.
And for me, just as a trans person, just seeing that we do have options now, you know, when back in the early 90s, if you were trans in Albuquerque or in the Southwest, your only real option for trans healthcare, and I'm using quotes, was the, you know, for hormone treatments is to go to Mexico and buy it and bring it back over. And that's what I did for a long time. And so knowing that there are doctors at the Trans Center, at the Truman Center and at UNMH that are able to help us and willing and wanting and affirming us is very exciting to me. You know, seeing how far we progressed over the last 28 years that I've been out is amazing, or 29 years actually, so it's really amazing.
I think everyone got a chance to go, I believe. So I guess my follow-up question for everyone is I wonder if we could talk a little bit more in terms of where we go from here. I heard bits and pieces in terms of you know, the centrality of care for, you know, those who are under 18, especially in the context of what is happening in Arkansas and the impending threat of an attack on trans kids at this particular moment. And on the other hand, I really enjoyed TK's response in regards to understanding trans people as experts. For me, that resonates in the work that I do as a trans studies scholar. As we look at the historiography of trans medicine, we can see that trans medicine itself historically over time from the beginning of the 20th century has been shaped by trans people kind of working with their providers to, you know, create a standardized, method of care, right? And best practices. And so I wonder, where do we need to go from here? Where are some gaps that we are seeing in providing trans health in New Mexico? And I'm also thinking maybe there might be some relationship in regards to like HIV/AIDS prevention. Like, how do we understand like gay trans men in relationship to trans healthcare, and just reproductive health in relationship to trans folks? And what are some topics that are of interest for you all to talk about in terms of where we need to go for trans health in New Mexico?
I'll just start off. For me, I think, trans health isn't just going to the doctors. It's not just going to see a primary care doctor. It's seeing yourself represented in the community. It's seeing, you mentioned gay trans men. Like, I know a lot of gay trans men that didn't know that they could be gay trans men. So just seeing that you can be that is very holistic. It's very healing. Like, oh, I can be a trans woman and I can like other trans women. I can be a trans woman and be with a cis woman. In our community, we have some arbitrary rules that I'm sure in every community they do it. We just make up that if you're going to be a trans woman, you got to be, this is what it looks like. And just breaking down those barriers will get more trans people into hospitals and in to see primary care doctors. From this end, just the way society is changing so fast, it's to me, it's going fast. So I'm very excited.
I'll just say something in relation to the reproductive health discussion, which is that part of my job in family medicine is working on our labor and delivery service. And so, family medicine is one place where we can start to kind of bring all these things together in an ideal world. And so making just competent people who could do full spectrum gender care, I would say. So they're not like, well, I do hormones, but I don't know any of this other stuff, and I'm not going to address the rest of you as a human being. So kind of making sure that all the rest of just the human experience is not ignored in the box of transgender care.
I would echo what Kate has just said. I mean, right now, my first question for my trans patients when they're coming to see me every 3 or 6 months is, have you got signed up for the COVID vaccine? It has nothing to do with their hormone status or their surgical status. It has to do with their being a human being as part of a primary care practice. I need to be attentive to all of their healthcare needs. And that's, again, why I would personally like to see more and more transgender care being incorporated into the overall primary care framework. There will always be a place for dedicated clinics, don't get me wrong, but I would like to see trans care be transformed from something exotic and other into just something that's part of day-to-day practice.
Yeah, I appreciate the treating trans people as whole people sentiment. I do have the same sentiment, but I don't want to repeat that. I guess I have one really specific concern for the future of trans care is regarding reproductive justice as we start integrating more adolescents into the sort of legal framework of our practice for trans people, and more adolescents are able to transition. There's then a reproductive justice issue where a lot of trans folks who go from puberty blockers to hormones and don't have a good idea of what their future reproductive plans are, may often, in some cases, but not all, end up not being able to have kids the way that they wanted. And so that's kind of an issue that there's not a great solution to at the moment. And like, it's one that a lot of people sort of like argue against the legitimacy of trans adolescents altogether regarding, because like this reproductive justice issue, but I don't think people who are making arguments against the legitimacy of trans adolescents actually understand the reproductive justice issue. So I think better understanding like what the actual like barriers are in terms of like if somebody is an adolescent and they're not sure about like what their reproductive future would look like, that requires like having a provider who really can work with them as a whole person, more so than it requires us to like legislate against adolescent transition. Does that make sense, I guess? Okay.
I just want to follow up quickly on the reproductive piece. I mean, the challenge is not just specific for trans folk. It's that assistive reproductive technologies is available only to those who can afford it. It's not considered a core healthcare component, and so unfortunately, it is one of those things that's only available to those who have a substantial amount of money, because it's not cheap. And I think that's something that we, as a society, need to look at and to resolve.
Yeah, that's a really good point, is like assistive reproductive technology being more available to everyone would benefit trans people greatly. Thank you.
Yeah, thank you everyone for these really thoughtful responses and really kind of pushing us to think about reproductive justice in different types of frames and frameworks. I think that that's a really important part of what I had in mind when I envisioned this panel in terms of different ways about talking about trans health. I think being capacious about access in terms of assistive reproductive technologies and you know, kind of the treating trans folks as kind of whole subjects as they're kind of accessing care. And so I wonder if we could, the final question that I guess I'll pose, and then maybe we might want to start taking questions if there's questions, and if there aren't questions, then I can certainly ask more questions. But the final question I would say are what are the obstacles, right? So for Bunnie in particular, Bunnie mentions kind of the lack of the representation, right, of trans folks in the medical profession in general, right, in terms of having a provider that looks like you and knows kind of your trajectory being like one obstacle in terms of accessing healthcare. But you know, what are other current obstacles that we are seeing aside from, you know, cost and then also visibility? So however folks want to begin to take that on would be great. Thank you.
I think for me, I think for a lot of trans people don't go to the doctors because they're afraid of the unknown. You know, they've been to the doctors. A lot of trans people don't have insurance, so we do go to the emergency room a lot and to urgent care, and we get treated badly. Luckily, I've never been treated badly, but I know some trans people who have been treated badly, so they just don't follow up on primary care. So that's one of the hurdles. And then just knowing where to go for primary care as a trans person is hard. You know, luckily I know where to go because I'm part of the Transgender Resource Center, and I'm well connected with the Truman services. You know, for over 20 years, I've known what they do. So, but a lot of people in the community don't know that they have that option. So just knowing where your options are for primary care is like the biggest hurdle.
Yeah, and then on top of that, I think that a lot of, even if like the provider is really well trained, like office staff and nurses and pharmacists are often, like in my experience with like my transition care, those are the providers who I've had to like educate the most and who often make me feel unseen or disrespected. It's like being called ma'am by like pharmacists who are handing me testosterone and things like that. Like those types of things, just like having interprofessional education that's not just educating physicians, but is also educating future medical assistants and phlebotomists and nurses. Like everybody should be trained to communicate in a way that's affirming to everybody.
Yeah, I think that's one thing that is so nice about Truman, is that people can kind of rely on the entire staff being competent and affirming, and not just the provider, which is why I mean, as something getting in the way, the Truman Clinic, our gender clinic, is backed up for new patients again, like 6 months or something. Like so even though I know that there are tons of providers in Albuquerque that want to be doing this work, and Truman wants to expand, it can't just be in specialty clinics. And so getting the capabilities into, and not just the capabilities, like TK is saying, is like it's useless to have trained providers if you don't have an affirming environment, and if you don't have anything in the clinic and in the healthcare system that feels representative of you and your experience. It's just not gonna work. So yeah, that is one big hurdle, I think.
Dr. Crandall, if I could put you on the spot, but it's because you've devoted a lot of time and effort to systems-based approaches to try to include this kind of training and information at multiple levels across the Health Science Center. And I just want to make sure you had the opportunity to talk a little bit about what you've done.
Yeah, so we started really, as I mentioned, as a result of the Affordable Care Act. There's a mandate to provide competent care that does not discriminate on the basis of sex and gender. And so I do have to actually take my hat up to Steve McKernan, who said, we are going to make our health system welcoming and to remove our barriers to care. And perhaps the biggest barrier that we have, which is our electronic health record. The electronic health record is based in a very sort of staid model. It's a computer, essentially, it's a computer program. And so it wants to see things in one particular way. And so sex, it really only sees sex, doesn't look at gender traditionally. And so we had to modernize our system and adapt it to make it more welcoming. And we still have ongoing challenges because we're relying on a big corporation, Cerner in our case, to make ultimately big changes to make the system much more effective and open to a diversity of sexuality and gender. We still have many issues that need to be addressed. Perhaps as folks have pointed out, that it's really the staff that perhaps can resolve some of these issues, and also they tend to create them. And so when we rolled out the advancements in our electronic health record, we trained about 1,200 frontline staff members about sexuality and gender, and really did a lot of focus on trans individuals. And I think we were pretty successful in rolling it out. We had really very few complaints, not too many hiccups. We had problems with parents and when we're asking about the sexuality and gender of kids. So that created a bit of challenge. Jumping up just a little bit forward to today, I see a looming problem as a function of our virtual visits and televisits, and the way that we have traditionally collected information in our health system is to do it in our face-to-face encounters. And we believe it's important to allow individuals to tell us how they identify, not to have somebody else fill it out, that we really want an individual to do that. And we do that through a process which we call our About Me form. And but over the past year, we've had very few face-to-face encounters, and it's not ideal, I think, to be asking individuals these questions sort of in a Zoom environment. And I'm concerned that the quality of our information will drop off, and so I think we need to be attentive to that. I'm going to make a comment. I maybe would like TK to kind of follow up on this, which is we've done a lot of education. We have over the past 5 or 6 years have done a fair amount of education of mostly of our medical students, and we're working to incorporate this educational component across the spectrum of our health service, our health science programs in nursing and in pharmacy and PT, OT, to really raise awareness of these topics. I have found that the students are hungry for the information. There's really no big barrier for our learners. The challenges that we have are really with our older faculty who weren't trained on the topic or less aware of these issues. And so those tend to be the biggest structural barriers where we need to make advancements. In general, though, it's not a problem. It's just really more raising awareness of the topics. And I don't know if TK can talk about all the work that they've done to really educate our medical students. And really, I think have been quite open to the topic.
Yeah, I would agree with that. The work that we've done has largely been about like communicating in an affirming way, such as like asking people how they prefer to be referred to, which is really like, if you're like, for example, already asking, how do I pronounce your name? It's really no different than like, how do you prefer that I refer to you, ma'am, sir, something else? Like, we already give people power in some ways. And so it was really about like telling people how to give patients power. And they're like, oh, great, I love that. Like the learners want to know that they don't have to have all the power in the situation, but like you said, the older providers are kind of used to it working a certain way. And that's certainly not true for everybody, but that's like the trend that we see. But yeah, it's certainly changing. Like for instance, faculty that we didn't think would be amenable to putting these changes into their curricula ended up seeing the benefit and the lack of any real hassle. And so by making that case, and John Holz, my roommate and co-president of ELSA, is also like really good at sort of making the point that this is easy primary care that anybody should be learning. And so that is, if you can make that point, it starts to become easier for providers to see, even experienced providers, like, okay, maybe this is easier than treating diabetes or easier than any of the other work that I do, is to just give my patients a little bit of power in this situation.
And I would just like to note that most times trans people are leery of medical providers, and in a state like New Mexico, a minority majority state, the majority of us are people of color, and so we have the double hesitancy. So when we go to the hospital, like every time I go to like urgent care to see a doctor, they ask me if there's any chance I could be pregnant, and I tell them up front I'm transgender, and they keep asking me that, they ask me the same questions, and it doesn't bother me, but I understand that it can make other trans folks uncomfortable. So it's just sometimes not even, you can say the nicest things to us and we're like trigger happy. You know what I mean? We're just ready to get our feelings hurt because that's what we're used to. So I just want to point that out. And I appreciate all the work that all the doctors and their staffs are doing. I appreciate you guys so much.
So as Bunnie points out, I mean, some of the advances we've had in some of in state law have been to make our processes of changing birth certificates much more easy. And we've also aligned our electronic health record to make those processes much more simple. But it can have that impact of, say, if you change the sex marker from male to female, and they don't know, they're going to ask those questions. And so it's really important for us to train all of our staff that they need to be open and to really kind of look at the records ahead of time. And some of the things that I think that we need to do in terms of our electronic health record is we don't have a great process, for example, in Cerner to develop an organ inventory to really kind of know what for each individual are the things that we need to focus on for preventive health and the like. Epic, like Presbyterian does, has a little bit more easy system that works better. And we've had ongoing trouble at UNM because of radiology, and we really have to work on warm handoffs, which means that the ordering providers should share information that's critical to providing good customer service to our patients, to let them know what's coming up and some of the things they might anticipate with the individual, so that every person gets good care.
Thank you so much, everyone, for your responses. I've learned a lot as the moderator of this panel, and a lot of what Bunnie and TK have brought up are a lot of my own concerns as a trans person myself, and my perspective, it resonates a lot with what you all are saying. So I appreciate your voices and contributions to the panel as well. And I guess I wanted to, before we go to questions, we're doing pretty good on time so far. I'd like to give the panelists opportunity to give any kind of comment that they want to, that my questions probably maybe didn't capture. So if folks have anything they'd like to add to the general discussion before we open up for questions, I'd like to give the panelists the opportunity to do that. And then for our attendees, I'd like to ask that you drop your questions in the chat, and I will be monitoring that. And I'll read the questions, and we'll do question and answer that way. So I'll yield to our panelists for any kind of comments they wanted to offer that were not captured by the questions. And then we'll go ahead and go to questions from our attendees. Thank you so much. All right, so attendees, please drop any questions you might have.
Just some of the other things I'm just going to comment a little bit on what Kate had talked about, or our affirmed name or preferred name that we have in our electronic health record. So we provided an ability to record an individual's name that they would like us to use when in our interactions with them, and we've developed a bit of a kludge process to also collect pronouns, where we put those pronouns along with the affirmed or preferred name. The challenge is that it's a workaround system that we've done, and so it doesn't propagate, for example, throughout the health record as easily as we would like it to be. So we, as an advancement, really need our companies, our business partners, to develop processes so that it makes this much more easy to do and more consistent, because we end up having challenges of prescriptions need to be in legal name. That's a requirement that by law, and it may not match a person's preferred name, and so that's another issue that that creates problems.
I was wondering, since nobody's dropped any questions in the chat, somebody just did, but I was wondering where we are in terms of data collection. Like, are we able to identify like trans people through something other than like gender dysphoria diagnostic codes?
So as part of the process, we elected at UNM Health Systems to collect this information as part of core demographic information. Many other health systems have taken the approach where they would have this information collected in a provider encounter, and it would be dropped into maybe a social history or some sort of past medical history component, which makes it harder to identify individuals. We elected to do it in a demographic approach so that we can identify individuals based on their demographics as they report them. And the challenges is that there's always errors in data collection and the way that information is transcribed, because it goes from paper onto the computer. And so there is a fair amount of misclassification that makes it a bit of a challenge. So it helps to be able to verify the information along with maybe some medical history to make the information correct. So that does become a bit of a challenge, but we do have that capacity. We originally, when we started out, we had probably 70 to 80% of our patient encounters capturing the information. The remainder either unavailable because the patient was too ill to do it, because we insist that this is information that the individual shares, because it's a self-identification, how you identify. And so if we don't get back to it, that information isn't updated, and we need to improve our processes for updating the information so it's of best quality.
And if I could go off on a tangent to that, I also hope for the future that we will see more representation from trans and non-binary individuals in the medical professions themselves, not just medicine, but all of our allied health professions, nursing, pharmacy, physical therapy, respiratory therapy, etc. We need to practice what we preach as far as being inclusive, and I think as we do include more people with gender diverse backgrounds in our own professions, it will help us to create a more accepting environment for, and a more inclusive environment for our patients. And right now, as Cameron mentioned, we don't collect that data at all. It's not addressed in any sort of systematic way, and there are lots of discussions to be held about that.
I do think with the positivity that the trans youth are getting, trans and non-binary youth are getting, especially from the medical field, that pretty soon there's going to be a lot of trans and non-binary doctors in the next 5, 10, 15 years. So, y'all are laying the groundwork for that, and TK, yeah, y'all are laying the groundwork. We get told so much the narrative of trans folks is that we can't be. They only tell us that we can be these low-paying things, or but I know trans folks now are going to college, so get ready for some trans doctors and pharmacists and nurses and x-ray techs, and we all are helping lay that groundwork along with TGRC. So thank you all.
Wonderful. Thank you all so much for these responses. So there's 2 questions in the chat, and one seems relevant to the question that, or the topic that Dr. Crandall, that you were talking about. So Miranda Aragon asks, can we add it to healthcare maintenance checklist, just as we ask about depression and alcohol use every 12 months? And so I think this is specific to the data collection that you were referring to.
I definitely think that is something we can do, to incorporate that into our general kind of preventive health screening checklists. Like right now, you have to, the preventive health checklists are tied to the biologic sex marker. And so you have to be aware of that. And right now, providers need to individually manually move things so that it matches. And so we have, we could definitely work on automating that and making it a more consistent process.
Thank you. So the question that Melissa dropped into the chat is, Dr. Stuenkel mentioned legislation in Arkansas that would affect care for the transgender community. Can folks discuss how healthcare professionals and others can help shape health policy positively?
I will start. I'm actually going to go on like a quick side route for a second, because something TK said made me realize that I feel like this discussion wouldn't be complete if we didn't mention the unhelpful, everyone's least favorite diagnosis of gender dysphoria, which is as what I see day to day is just plain inaccurate for the majority of folks that I provide gender affirming services to, and I don't think that's unusual. And so I think that's like, we could have like an hour-long conversation just about this, but that hopefully things will be moving away from needing to use that diagnosis. I know that there are some providers that just currently never use it. I feel like at our clinic, we use it a lot for simplicity, and that, but that I talk to every person who it's in their chart to kind of make sure that they're okay with the functionality of using this diagnosis in their chart, and that it gets us some things that we need simply through insurance. But I think that is like a much bigger discussion and something that we should continue, because it's really important that in the future, hopefully DSM changes to adding like gender incongruence as a perfectly reasonable diagnosis. So that's a side note. And then moving towards what you were just asking about Arkansas and other things. So I, unfortunately, in the majority of my day-to-day life, like fight individual things of like getting hormones for specific individuals from their insurance companies. I am less experienced at the bigger political fight, which I personally know that I'll probably I'll dive deeper into in the future. But like all I do right now, which is sad, is like sign a lot of online petitions and send emails to the governor of Arkansas and things like that. And everyone can do that, but I would love to hear what other folks are doing. Bunnie, TK, Frank, everyone else, anyone else. Thanks.
So what I'm doing is I'm kind of running for office. So that's what I'm doing. We're very lucky in New Mexico. I keep saying we're very lucky in New Mexico, and a lot of people might not think that, but we're very lucky, not just trans folks, but all the folks in New Mexico. We're very lucky to live here. And yeah, so I'll be happy, you know. I work peripherally with like policy and stuff like that, but I'm either going to be running for city council or state senate pretty soon, so I can work more hands-on with state policy and stuff like that.
In terms of local support for these issues, Equality New Mexico, for example, supports these issues, and as Bunnie points out, we are lucky. We have not had huge problems in our state. We do have legislators who often introduce trans unfriendly bills, but they generally aren't going anywhere in our current environment. So that's fortunate that we have that case. Not everyone is so lucky. But Equality New Mexico and New Mexico Transgender Resource Center are probably the two big organizations that are working to keep that process working appropriate.
And providers who are doing this care can also align themselves with the WPATH, the World Professional Association for Transgender Healthcare. Their name carries weight because they are an organization of professionals. And so if you are writing a letter to your representatives or the representatives of Arkansas, for example, then leveraging that name is important. And yeah, I think that the other important things have already been said.
Yeah, and I'll just add on very briefly, I think coalitional politics become increasingly important here. So, you know, really kind of working with folks who already work on reproductive justice and asking them to really kind of reorient what that politic particularly means in relationship to who they're representing and how. And I think this is part of the larger conversation that you all were talking about in terms of just what reproductive health and justice means for trans folks, and really kind of invigorating partnerships on folks who are already kind of representing, for the most part, women of color in New Mexico and access to reproductive health. And so, you know, building those type of coalitions is one way definitely to shape and change policy. And so I think we have time for this one last question, which is again from Melissa. And Melissa asked, Bunnie's comment about the groundwork being laid for an increase in transgender healthcare professionals and so inspiring. What are there ways we can work to speed up this progress? What are the barriers? And I'm just gonna give my take on that really quickly. First, as a professor who does women and gender studies and is at UNM, the main campus, I think supporting our trans students at UNM becomes really integral. I think that it's very hard to be an undergraduate and to be trans at any four-year university, and especially in a place like New Mexico, where our students are mostly working class and already are facing other barriers to doing well in school. And so being able to, apply to graduate school, that's where some of the gaps are, right? Assuring the students, we're supporting the students and investing in our trans students. And I think a investment on the part of the chancellor of the campus and the provost in, something like trans studies or partnerships between, the health sciences and the work that I do in women and gender studies would be a great place to start to really kind of, improve access to graduate school and imagining folks in the having folks imagine themselves in the medical profession. But we'll let the panelists respond to that.
I think that the discussion that we had earlier about data collection, it brings up an important barrier that even when we are accepted, we're not seen because data is not collected on our orientation. And then like the pipeline programs that get people into healthcare fields in New Mexico, those are really big ways that people from working class families get into high school, or not into high school, into graduate schools. Those pipelines don't see gender diverse people or sexual minorities. They're very like race and maybe income based, but primarily race based. And so those issues kind of, there's like equity that is happening for groups that is not happening for gender diverse individuals because data collection is not happening and we're not being recognized.
So the difficulty here, and I've participated in these discussions a number of times over the years, is that for some people, particularly those who are in positions of policy, that asking these questions is seen as potentially stigmatizing and a source of potential discrimination. And my personal response to that is, this information is stigmatizing only if we choose to make it stigmatizing. But I'm curious how others feel about this.
To say that it's stigmatizing, I think perpetuates. It's a vicious circle when you say, oh, we can't collect that information because they'll get discriminated against. It sounds like you're about to do the discriminating.
So yeah, so I can make a couple comments about that. So on our secondary application, in the applications in medical school, there's a centralized application process. And for the past couple of years, they've been asking about gender. So that process has been working for a couple of years, and we were supposed to have started collecting sexual orientation information this year on our secondary. Unfortunately, I just learned last week it got dropped by mistake. And so it'll be next cycle. But I agree, it's like we actually surveyed the students, and people are willing to share the information provided that it's information that it's not broadcast, it's really kept for statistical purposes. It's confidential information, just like race, ethnicity, disability, veteran status, all these types of things that we use to help improve the diversity of our student body. Treating it the same way is important, and people do find it valid. That's not 100% that everybody feels that, but the majority does feel it's okay.
I do want to celebrate that. Normally it's me, another lone trans person on the panel. And not only do we have trans people on the panel, I won't see people's names, but I see some trans folks and as our guests. So that's very inspiring for me as a trans woman to not be the only trans person in the whole entire thing, and to have trans people on both sides of the conversation is very, very, very exciting to me. So whatever y'all are doing is slowly working, but it's working. So like the person asked, the way to speed up the progress is, I wish I had an answer to that. But it's working, it's not progressing as fast as we might like, but I can tell that it is working.
I think that there's, in like politics, there's like an issue of accelerationism. Like you can't speed progress up too fast or else people react to it in a really negative and violent way. And so the work that you do in your like interpersonal space of just like thinking about trans people and including trans people is kind of radical. Keep doing it.
All right, we are right at 12:59. So we haven't gotten any more questions in the chat, so I think we're at a good place to kind of end our conversation. But I really want to thank our panelists for all of their thoughtful answers and all the resources that wealth of information that they shared. And thank you for taking the time for being on this panel. I look forward to working with you all in some other way in my capacity as director of the Feminist Research Institute. And thank you, Melissa, for bringing us all together. And thank you to everyone who attended. So Melissa, I'll take it to you if you have any kind of concluding comments.
Thank you so much, and thanks again to all of our panelists and to you as our moderator. This was really a wonderful and informative panel. I know I learned a lot, and I know just in my short time working in medical libraries with medical schools, I've seen so much change, and I'm just so excited to see how that is continuing to accelerate so that we can make sure that we're providing the best kind of care for all of our patients. So again, thank you so much. This was really wonderful, and I greatly appreciate everyone who attended, and with a special thanks to all of our panelists. Thank you so much.